If the child has got a hip extensor weakness, the child will have difficulty in climbing up the stairs. So that is why the climbing of stairs, whether climbing up or climbing down, becomes very important to us. The other thing is whether there is any sort of waddling, that is a movement of pelvis from side to side while walking. So the parents have not observed this part, but it is important for us while taking history, we have to ask this question about waddling from side to side. These 2 points will give us a clue that the weakness would be proximal. The next thing she has also mentioned that the slipping of the slipper from the foot. That also gives a indication that the child also has a distal weakness. So here we are dealing basically with a weakness. There is a bilaterality. At the same time, there is an asymmetric weakness where the left leg is affected more than the other. And there is also proximal and distal component of the two. The only issues over here are there are some balance issues also in the child. So here we can just arrive at a conclusion that the child has a gait abnormality, whether it is an ataxia or whether it is a high stepping form of a gait. This has to be confirmed on further detailed history and also by examination. So just with this point, I would also want to give you a just brief overview on different type of gaits that we come across in our routine day-to-day practice. So this is one such gait. To observe clearly, this boy must be around 13, 14 years old, is having difficulty in walking. He is requiring 2 people to hold his hand. And he is having some balance issues, but just keep observing his leg. I'll play the video from the beginning. Okay, just observe his leg. The way he is keeping his right leg, the toe touches first, and then the heel touches, and it is as the and he's lifting the knee up and then touching it up. That is more of like a high stepping form of a gait. This type of gait we usually observe in GBS children, but syndrome. But the other point over here is there are some balance issue. There is some ataxic component also along with this type of the gait involved. So this is an example of high steppage gait. Similar kind of a gait we also see in foot drop. If a peroneal neuropathy is there also, you get where the dorsiflexors are weak. That is why the child is having this form of a gait. They produce a sound, thup, thup sound will be heard. That is a high steppage form of a gait. The next type of the gait, this child was seen in our OPD. So she is around 10 years of age. She had a history of neonatal hyperbilirubinemia, did not require exchange transfusion, but required a prolonged phototherapy. So this is the type of gait. It's more of a dancing form, and kind of some posturing is happening in both the upper limb. And if you can look at her face, there are even movements like this going on in the face. Those things are also happening. And the neck is also kept in a torticollis on top of a type of a posture. So this is more of a dancing, at the same time some tightness. This is more like a dyskinetic gait. So this we commonly see with chronic bilirubin encephalopathy or the kernicterus sequelae. Then other common thing that this is ideally the way we have to check the gait, because the child has to be minimally dressed while checking the gait. And if we observe this girl, just observe the left side of her body, the way she is moving, especially when she comes towards the camera. Yes, this is the posture. So left leg, if you can see, that the left leg is laterally placed like this and it moves around this way. And if you can observe that symmetry of movements in the upper limb, that's the arm swing that we call, the left side of the limb is not moving much compared to that of the right upper limb. This is a classical hemiparetic type of a gait that we see in hemiparetic cerebral palsy or a static encephalopathy. And whenever we check a gait, we have to make sure the child is minimally dressed, make sure the child is able to walk in the straight line. Tandem walking should be checked at the same time. Then make the child walk on toes, the toe walking both forward and backward. Then make them walk on the heels, heel walking both forward and backward. Those are the ideal ways of checking this one. Just today I came across with this patient. You can see the way she is walking. So here, observe her closely. We can make out that she has a lot of spasticity. Some asymmetric spasticity, the left is more involved when compared to the other. But if you see the lower limbs, this is a typical crouch gait. Crouch gait is something, but the knees are flexed. There are also the dorsiflexors are being weak. The child is on more dorsiflexus point, and even the child is on the plantar flexed posture on the left side. So this is a sort of crouch gait that we get in spastic diplegia. So spastic gait is something like walking in water. So if somebody has walking, the amount of pressure they will put to walk in the water, that is something that is what we actually expect to see in spastic sort of a gait. This is another gait. The child is just not able to balance herself. She's struggling a lot to balance. If you can see both her feet, they are wide apart. She's trying to catch on to object before she starts walking. And she's being wobbly. So this is what we see in an acute cerebellar ataxia. So these things are very acute cerebellar ataxia, something like phenytoin toxicity. We do see this case very commonly, phenytoin toxicities. The other things are any cerebellar demyelination, cerebellar strokes, any even space occupying lesions in the cerebellum. We get this sort of a gait where the child is just trying to balance herself before she starts walking. A happy male child with this sign, all of us know this is a Gover's sign. And this sort of walking is a waddling type of walking. Why is it called waddling? If you can see, he's very straight. There is a lumbar lordosis over here. And his pelvis is moving from one side to another because of the hip extensors that are being weak. The proximal muscles are more involved. And this is the waddling type of a gait that we see in muscular dystrophies. This is a very rare case. That is why I just wanted to show this video. So this boy is around 5 years of age. And he has difficulty in climbing up the stairs. He also has a lumbar lordosis. Not much of a waddling. Putting all his pressure to go up. So basically, when we see this exaggerated lumbar lordosis, and when they try to difficulty in climbing upstairs, we usually think of a proximal involvement. That is, a muscle involvement is one thing that we think about. The other thing is a neuromuscular junction abnormality. So this child had a congenital myasthenia, and that type of a gait. There is one more video that I will show at the end of the presentation where they walk with both the feet, which is being in the inverted posture. So that type of a gait is called as a synoptic gait, and that we see in DOG7 mutation of congenital myasthenia gravis. These are a bit high-fi, but the usual things are you should be able to differentiate between hemiparetic, dyskinetic, ataxic, high steppage gait. This is very important in all the clinical practices. Okay, so by Hasnath's history, we know that the child has a gait abnormality where she's trying to find a balance. And there is also some issues with the dragging of feet. It could either be an ataxic or it can either be a steppage. This is the type of conclusion that we arrive from her history. So now we have to look for the other aspects of the history, and we also have to confirm these features by the examination points. Hasnath, you can go ahead.
So coming back to the history, this child also had a history of tingling sensation all over the anterior chest wall. There was no history of any involuntary movements or twitching, no diurnal variation of symptoms. Sensorium and speech was completely normal. No loss of consciousness, no history of memory loss or emotional disturbances. No history of any blurring of vision, screen ptosis or diplopia. No facial asymmetry or deviation of angle of mouth. No history of any difficulty in chewing, no vertigo, hearing disturbances or tinnitus. No nasal regurgitation or nasal twang of voice. And there is no history of any difficulty in swallowing. The child was able to appreciate touch and pain sensation, no bowel or bladder disturbances, no history of any neck pain. And
Okay.
no history of cough.
Hasnath, I'll just interrupt you for 1 minute. So over here, whenever we deal with any case of CNS symptoms, the important things are the other Neuraxis symptoms should also be ruled out at the same time. So she had described in detail to us about the gait disturbances and also of the fever. At the same time, we should also make sure that the child is not encephalopathic. So the higher mental functions history has to be asked in detail. There were also some positive sensory symptoms in the chest. That detail also have to be taken, like able to appreciate touch and pain is also equally important. Bowel and bladder symptoms should also be asked for. Apart from that, other motor system involvement, cranial nerve involvement, facial involvement, all those history should also be asked in detail. Okay, now once we finish all the Neuraxis history in the HOPI, the next thing we have to go is to find out the etiological aspect. Go ahead.
No history of any cough, throat pain, no history of vomiting or loose stools, no history of trauma, no seizures, no recent immunizations, no history of animal bite, injection of unknown medicines or other substances, no history of any contact with the tuberculosis, no history of travel or contact with the COVID-19 cases. Past history, no similar illness in the past, no prior hospitalizations, antenatal, natal and postnatal history were uneventful and developmental history normal up for the age. Immunization history, immunized as per national immunization schedule, BCG scars seen, optional vaccines were not taken, no adverse events following immunization. Coming to the dietetic history, shares family pot diet and child is getting around 1000 kilocalorie per day and around 30 gram protein per day against the requirement of 1530 kilocalorie per day. Family history, this is a second child of non-consanguineous marriage, no similar illness in the family. Socioeconomic status belongs to middle class family as per modified Kupaswamy classification. So the summary so far, we have a 4-year-old girl child, second child of non-consanguineous marriage with a history of fever followed by acute onset gait disturbances. The child has a lower limb weakness with distal and proximal muscle weakness, asymmetric involvement initially in the left leg, gradually in the right leg too, with a history of sensory disturbances in the form of paresthesias over the whole of anterior chest wall, no upper limb weakness noted, sensorium normal, no seizures. So, what is we are dealing with regarding the localization?
So first thing is the child has just gait disturbances. There is asymmetric involvement. There are just paresthesias over the whole chest. There are no upper limb weakness, normal sensorium. So we have to, when such a case comes in front of us, the whole Neuraxis should come to our mind. Are we dealing with the upper story, that is cerebrum? So usually if the child has any cerebral symptom, there should be some involvement of the facial muscles. There will be speech disturbances will be there. Her sensorium will not be normal. She'll have a seizure. So that part is being rolled out. So we are sure that we are not looking at a stroke or an encephalitis sort of a symptom here. The next thing comes to the brainstem. So brainstem involvement will also have a lot of cranial nerve involvement. So those cranial nerves are not getting involved, respiration is stable, the child is not having other issues. So even the brainstem is also being ruled out by this condition. The third thing is cerebellum. Cerebellum is still a possibility considering the examination finding, because we don't know whether it is an ataxic gait or a high steppage gait. It can be a bilateral, it can just be an isolated vermis involvement, which can also happen with only gait disturbances occurring in the child. That is still a possibility. We should consider that in our mind. The next thing comes to the anterior horn cell. So diseases affecting the anterior horn cells or something like an infection or chronic infections, chronic things like spinal muscular atrophy, acute ones like poliomyelitis. So even those things should have more of motor weakness, but these sensory symptoms like paresthesias are not being explained by the anterior horn cell. The other is myelitis. Myelitis is still a possibility. Myelitis just means the whole of the spinal cord is getting involved, but at what level we have to exactly confirm by our examination finding. So spinal cord possibility is still there, cerebellar possibility is still being there. Then comes to the neuron, whether are we dealing with a neuropathy. Neuropathy should have distal involvement more than the proximal involvement. So that itself, there is both the involvement that gives a slightly not very, we cannot keep neuropathy as one of the major differentials over here. The other thing is whether it is a radiculopathy. Radiculopathy, what I mean over here is GBS. So GBS usually will have the same kind of presentation like how the child has presented to us, with some acute onset gait disturbances, some high steppage or ataxic sort of a gait. At the same time, the child is also having some paresthesias. But the pointer against GBS or the involvement of any radiculopathy is the root pain. If you have seen a child with GBS, they will have a lot of root pains. They'll cry from pain. They will not let you touch their limbs. So these are the usual pointers towards GBS. That is one thing which makes us think GBS is slightly unlikely compared to the other differentials. Then when it comes to skeletal muscle, isolated muscle involvement with the paresthesias cannot be explained by. So that is why we don't think much about the muscle. So overall, this is how, like a mathematical calculation, this should go in our mind whenever we are seeing any neurology patient in front of us. The first thing is whether what part is involved. So here we are thinking more of a cerebellum. Second is whether it is a spinal cord is another possible, that is another possibility. Third is whether it is still a GPS without much of a radicular pain, that is a radiculopathy is there. So these are the 3 pointers that we came by at the end of our history. The same thing I've explained in detail. So muscle involvement, the common cause are myopathy, muscular dystrophy, which are all chronic. The acute ones can be something like thyroid, hypothyroidism, hypocalcemias, phosphorus disturbances, electrolyte, which should steroid, if the child is on a chronic steroid usage for any conditions. That also, like the child with nephrotic syndrome has presented with similar issues, we should definitely think of a steroid usage over there. Something very acute, snake bite, OP poisoning, all these things can also happen, which affects the neuromuscular junction. Neurons, neuropathies are something that we're not considering much in this case, but we should know the causes of neuropathies as well. Radiculopathy is still a possibility, and the common radiculopathy that we come across is GBS. Then anterior horn cell, where SMA is unlikely, and enterovirus and poliomyelitis are other ones which can affect the anterior horn cell, which we are not very convinced, mainly because of the sensory disturbances this child has got. The spinal cord, we are still thinking as a possibility. We'll discuss about it later. Brainstem ones are Bickerstaff encephalitis is another possibility, but the brainstem features are not there in this child, like there are no cranial nerve involvement over here. Cerebellum is still possible. A demyelinating cerebellar lesions can still have this kind of an involvement. Cerebral involvement, we are not thinking of, considering the child has normal sensorium, normal speech, and there are no seizures. So one important point that I wanted to highlight is, so most of these neuropathies or neuronopathies, if you are dealing with these children in the OPDs or in your inpatient basis, the first thing is to look for this chronic ones, not the acute ones. Chronic ones will have this wasting of the extensor digitorum brevis. So extensor digitorum brevis is a small muscle that is seen as a fullness which is present in the lateral dorsolateral aspect of the foot. So if the fullness was missing, that means we are dealing with a chronic neuropathy condition, or even a spinal muscular atrophy will also have this absence of EDB, that is EDB wasting. Usually this can be the first sign. Usually the myopathies will not have an EDB wasting, but the neuropathies will have an EDB wasting. So whenever we are confused between myopathies and neuropathies, look at the EDB. That will give us a major clue in the diagnosing the conditions. So with overall history from Dr. Hasnath, we know that there is an asymmetric involvement, either a spinal cord or a cerebellar involvement is what we have got to know by the history. So next comes the examination part. Dr. Hasnath.
So coming to the general examination, the child was alert, cooperative, no pallor, icterus, cyanosis, clubbing or significant lymphadenopathy noted. Ear, nose, throat normal, no neurocutaneous markers. Vitals at the time of examination, child was afebrile, pulse rate of 90 per minute, respiratory rate of 20 per minute, and blood pressure 94/60 millimeters of mercury in sitting posture.
Anthropometry.
Anthropometry, weight 15 kg between 0 and -2 z-score, height of 106 cm between 0 and -2 z-score, head circumference of 49 cm between 0 and -2 z-score, and mid-arm circumference of 16 cm. So anthropometry was normal for age. Coming to the systemic examination, central nervous system examination, higher mental function, the child conscious, oriented, memory and intelligence normal, speech normal, and right-handed child. Coming to the cranial nerve examination of ophthalmic nerve, no anosmia, optic nerve, visual field, acuity and color vision normal, fundus examination normal, 3, 4, 6, no spleen ptosis or nystagmus, no diplopia, Extraocular muscle movement full in all directions. Pupil size and shape normal, direct and indirect light reflex present, accommodation reflex present. Trigeminal no deviation on opening jaw, touch and pain sensation normal, temperature not tested, jaw jet absent. Conjunctival reflex present. Facial nerve, wrinkling of forehead present, able to close eyes tightly, no deviation of angle of mouth, nasolabial fold normal, taste sensation over anterior two-thirds of tongue present. 9 and 10, no nasal regurgitation, uvula central, palatal movement equal, and gag reflex present. 8th num, no nystagmus, tinnitus or vertigo, rin is not tested. 11th num, able to shrug shoulder against resistance, movement of neck against resistance is present. 12th num, normal strength of movement of tongue, no fasciculation, tremor or wasting noted, no tongue deviation on protruding. Coming to the motor system examination, bulk, upper limb, mid-arm and mid-forearm circumference were 14 and 13 centimeter respectively, and lower limb, mid-thigh and mid-calf circumferences were 26 centimeter and 24 centimeter respectively. No wasting noted. Tone, upper limb normal, lower limb hypotonia noted bilaterally. Coming to the power, upper limb at the level of shoulder, flexion, extension, abduction, and adduction were grade 5 bilateral. At the level of elbow, flexion, extension, supination, and pronation were grade 5 bilaterally. In the lower limb, at the level of hip, flexion and extension were of grade 4 bilateral. The level of knee joint, flexion and extension, grade 4. At the ankle joint, dorsiflexion is of grade 3 bilaterally and plantar flexion grade 4. Eversion grade 3 right and left. Inversion is of grade 4 right and left. Reflexes, superficial reflexes, conjunctival reflex present bilaterally, abdominal reflexes present normally, bilateral flexor mute. Deep reflexes, upper limb reflexes, biceps, triceps, supinator were normal. Knee reflex bilaterally decreased. Ankle jerk was absent in the left side and decreased over the right side. No involuntary movements noted. Gait as of steppage gait or ataxic gait noted. Then sensory system examination, touch and pain normal, temperature not tested, cortical sensation normal, deep sensation normally present. Posterior column examination within normal limits, no cerebellar signs noted, no signs of meningeal irritation, skull and spine examination within normal limits. Coming to the other system examination, gastrointestinal system, abdomen soft, no hepatosplenomegaly, respiratory system, normal vestibular breaths and heart bilaterally, cardiovascular system, first and second hearts on heart, no murmur noted.
So from the overall, even with the examination has just added us to the points that there is left side asymmetrical weakness is there, where the lower limb is involved, the left is involved more than the right. Though power-wise, there is no major difference between the left and the right lower limb involvement. But if you see the reflexes, the ankle reflex on the left was absent, where on the right was depressed, but it was still elicitable. And both the plantars are mute, or we could not get an elicitable response with the plantar. We know that there was no palpable bladder, so we know there is no bladder bowel involvement, and there are some sensory symptoms in the thorax. So with looking at all these features, we will be thinking this could go more in favor of a spinal cord pathology rather than a cerebellar pathology, because in cerebellar pathology, we would have got a brisk reflexes at the knee, we would have also got a brisk reflex at the ankle, and the proximal muscle weakness would have been severe when compared to the distal. But here we are getting a distal muscle weakness which is more severe when compared to proximal, and the reflexes are all depressed or absent. That is why we are thinking of a spinal cord pathology. The spinal cord pathology that we are thinking is a myelitis, it is inflammation of the spinal cord. So at what level of the spinal cord is it involved? Different levels. So the sensory symptoms in the chest. Chest means either just at the left, above the manubrium sterni or below the manubrium sterni. For practical purpose, I have just considered as below the manubrium sterni. So we know that somewhere between the lower thoracic or the lower cervical or the upper thoracic, from that region till the lumbar region is involved. That is all we get to know by this localization. So where is it exactly getting localized to? If the child would have had only the thoracic thoracic region involvement, we would have got a spastic paraplegia. But here we are getting a flaccid weakness, and the weakness is very clear that we are getting it in the hip extensors and the dorsiflexors. That is why we should even think about the lower down pathology up to L5 could be a possibility. At the same time, even because sensory symptoms are present, we should think of a lower cervical or the upper thoracic till the up to T10 involvement explained by the level of the umbilicus. So we are thinking of a widespread pathology in the spinal cord. So something so widespread will not have the child to be this preserved. The child is still walking. There is no plegia. There is only paresis. So there is a widespread one, but it should not. It cannot be a confluent one. It can be a small patchy sort of a lesions present here and there in the spinal cord. That is what we get a brief idea by looking at the history and the examination. So the lesion could be patchy, and the lesion is definitely asymmetric because the left is getting more involved when compared to right. And one more thing that she has mentioned out, forgot to mention in the history is about the root pains. There are no root pains because in all the child with these sort of involvement, always look for the Kernig sign. Kernig sign is not only just positive in meningitis, but it will also be positive in conditions like GBS. Even they will have GBS children will also have some truncal involvement, just as the child to get up from the bed. Usually a GBS child will turn to one side and slowly place a limb support and then get up and sit. That is what they do usually. So those things are absent over here, which is again pointing more towards a spinal cord pathology. So this is a brief diagram to look at the spinal cord. This diagram may look scary, but you just have to remember basic tracts over here. So these are the spinothalamic tract, the anterior spinal thalamic tract and the lateral spinothalamic tract. The other tract that we have to remember is this posterior column. Then we have to remember about this corticospinal tract. These are the three major tracts that all of you have to remember. Then these are the anterior horn cells. Okay. So we are thinking of some pathology which has affected these regions, which are somewhat in the periphery, and it has not come to the central areas. If it would have come to the central areas, when we would have got even the cervical involvement, which is not there in this patient. And there is sacral sparing. So we know that the lesion is not in the periphery, it is somewhere here, just in the lateral part, not involving the central and not more towards the periphery. So this is what we are concluding with our history and examination. So whenever we get a case of spinal cord pathology, the first thing that we have to think about is whether the lesion is extradural. Extradural means outside this dural space, or whether they are intradural, that is within the dural space. If they are intradural, whether they are intradural extramedullary or intradural intramedullary. So here we are thinking of intradural intramedullary. Why are we thinking of intradural intramedullary? Is because there are more of element signs over here. There are no root pains. There is more of a diffuse involvement. Sacral involvement is not there. The one point which can go against this intramedullary is there is no bladder and bowel involved. It is still preserved. Child is able to indicate the bladder and bowel needs. So this is just an intramedullary anatomy. So what all conditions can affect? So basically in this child, I would be thinking more of either whether it is infective or whether it is demyelinating. That is non-infective demyelinating conditions. Demyelination is a strong possibility considering the fact that there is a widespread involvement. There are multiple patchy areas which are involved here and there. And the demyelinating possibilities are whether it can be a neuromyelitis optica, that is one thing, whether it can be multiple sclerosis, that is another one. If only sensory symptoms were there, we would have thought about vitamin B12 deficiency. If the only anterior horn cells are involved, we think about either enterovirus involvement, which is there. So the overall picture goes more in, so we have localized it to the spinal cord, and in the spinal cord, we have localized it, it is intradural, intramedullary. We have also seen that we are not thinking the lesion to be around the central canal. It is somewhere far away from the central canal and not more towards the periphery. This is the broad overview that we have got. So final impression is we have a child of 4 years of age with fever, just one single episode of fever, and acute onset lower limb weakness. So there are asymmetric patchy areas of involvement involving the lower cervical, upper thoracic, lumbar region. The possible etiology could be myelitis. And considering the child is not very toxic and the fever did not go on and off again, the infective ones are unlikely. So the possibility of non-infective ones like a demyelination is more over. So how do we investigate these children? So first thing, always we have to definitely rule out infection. So we are looking at a complete hemogram. At the same time, something like a leukemia, lymphoma can also be this widespread. So that is why we should look for a peripheral smear also. Get a creatinine phosphokinase level to look for any muscle breakage or anything that can aggravate these conditions. Then the next investigation would directly be MRI, whole spine with contrast. And if at all, if a long segment lesion, long segment means if more than 3 segments of the spinal cord are getting involved, immediately screen the brain. Look for any lesions which are present in the brain. Once we do a MRI and we know that there is an etiology in the spine and the brain, next we go for lumbar puncture. And always don't make a routine of sending all the CSF investigations together at one go. First, interpret the analysis report. Analysis means the protein, sugar, and the cell count. Now, depending on the protein, sugar, and cell count, then decide what investigation you have to send later, whether you want to send a culture or a gram stain or any viral bacterial panel, whatever it has to be sent later. Nerve conduction study can be useful in these conditions, based considering the fact that there were all these neuropathic symptoms where the nerve conduction study can be helpful. It is of more help in GBS because that will help to even prognosticate things. That is why we do a nerve conduction study. So if it is a demyelination, do not forget about sending the neuromyelitis optica, that is anti-aquaporin 4 channel antibodies and also MOG related antibodies. MOG is a recent one and it can have a recent one into the literature. Where the MOG can have different kind of presentation. They can present as isolated optic neuritis. They can present as transverse myelitis. They can present even the ADEM-like illness. So this is a spinal cord sagittal session. T2, and we can see that this is the hyperintense lesion which is seen. They couldn't get a better picture. There is some involvement of the lower lumbar spine also. So this is predominantly the thoracic region which is showing a thoraco and upper lumbar region which is showing a hyperintensity, T2 hyperintensities. That does explain the paresthesia symptoms and some part of the lower limb weakness in this child. So this is a long segment, definitely. More than 3 segments of the spinal cord are getting involved. So immediately we have looked into the brain. And in the brain also we can see these are the flare images. These are T2 flare images, axial sessions, where we can see these hyperintensities which are seen at the in the white matter and also at the junction of the gray white matter. Here we can see a predominant lesion over here. These are multiple patchy ones, and the important differential involving the spinal cord and also the brain could be demyelination. So just a broad overview I want to give, only one slide. So demyelination can be a number of things. A child can have demyelination without any positivity. So any child who presents with demyelination, whether it is an ADEM sort of a presentation or a longitudinally extensive transverse myelitis sort of a presentation, we do give them a pulse dose of steroids or IVIG, depending on their affordability and depending on the clinical severity also. So if the symptoms are not very severe, the child is not going into ventilator, you can directly give steroids. If a situation arises where the child is in ventilator, then you can decide between plasmapheresis versus IVIG. So that is a ADEM or longitudinal extensive transverse myelitis. If the child has only optic neuritis, you can directly go ahead with steroids. Steroids is pulse dose 30 mg per kg. Now, the steroid treatment is for 3 to 5 days. But what makes you decide whether the treatment steroids have to be continued for 1 month or 2 months or prolonged? That depends on your antibody positivity and also the clinical improvement of the child. So the next step, what you do is you do a CSF and look for anti-aquaporin antibodies and MOG-related antibodies. It may look very high-fi, but the matter is very simple here. Aquaporin 4 are nothing but these are the water channels. So where are these water channels present? In and around the ventricles. So they will affect all the organs in and around the ventricles. So if we can see here, all these circumventricular organs. So if you get an MRI lesion, which is having clear-cut just in and around these ventricles, we can strongly think about NMO and we can directly send NMO antibodies. Okay. So what is this MOG? MOG are nothing but myelin oligodendroglyocyte antibodies. So they will be presenting in all the myelinated structures. There can be a lot of confluent involvement can be there and they can present anywhere. They can affect basal ganglia. MOG can affect only the optic nerve. MOG can cause only the brain involvement. Sometimes a combination of all the three can also be caused with MOG. Actually, if you look at the child's MRI, one more thing that comes into a picture is whether it is something like multiple sclerosis. But the things which are going against multiple sclerosis are the lesions were not again perpendicular. They were not just perpendicular lesions. They didn't have those appearance of perpendicularity. though this child had some form of subcortical U fiber involvement and everything, that can still consider whether it's an early multiple sclerosis, we do not know. It depends thoroughly on how the child is going to improve with your treatment. So what I would like to highlight here is whenever a child with demyelination presents to you, the first thing is send the NMO antibodies, as that will help a lot to prognosticate further. And also keep a close follow-up of this child. The child will need a repeat imaging after 6 to 8 weeks. We should plan a repeat imaging. Look whether the lesion has completely disappeared or not. Okay, so this is how we approach a child with a gait abnormality. So here we have learned very clearly as to how we have to localization, which is very, very important. And once we localize, we can custom tailor make the investigation. So they did not spend much money on the investigation point of view. Thank you. Any questions? Do we have any questions here? Any doubts?
Thank you, Smily. That was a very good approach. I'm sure all postgraduates must have got a clear idea. That's why they are asking questions.
Either there are two things, either they understood or they did not understand. That's why they're not asking questions.
That's the question there, Smily, on the screen. You saw questions, Smily, on the screen? Steroid.
Ma'am, steroid?
Rita Kurian, can you unmute and ask? You saw that question, Smily?
Ma'am, I'm just trying to get it. Yeah, sure. How to decide duration of steroid therapy after the pulse to CSF antibody. So once, suppose consider that the CSF antibody was also negative in this. What we actually do is, once we give a pulse dose of therapy for 5 days, then I usually put the child on oral dose of steroids, that is omnacortin, 1.1 mg per kg is being given for 2 weeks. Within 2 weeks, we usually get a report of NMO or MOG antibody. Suppose both the antibodies are negative and the child has clinically shown good improvement, then we can directly taper the steroids and stop it in another 2 weeks of time. Suppose if the child did not get, suppose if the child, the antibodies were negative, the child did not have any issues, then we can stop it right away. Suppose if the antibody is positive, considering the MOG is positive. If the MOG is positive, then the steroids will have to be continued for a minimum period of 2 years. But the steroid will have its own issues, like there will be steroid toxicities, and the child will have to be managed throughout. So because of that, we use steroid sparing agents. The sparing agents that we commonly use are rituximab, mycophenolate mofetil, and in some conditions, azathioprine can also be used. But the duration of immunomodulation will be minimum 2 years for MOG. Similar with NMO. Even with NMO positivity also, the child will need periodic dose steroid sparing agents are commonly being used for it. Suppose if the child improved and the antibodies were negative and we stopped the steroids, but after stopping steroids, the child again deteriorated. And when we redid a MRI, the MRI showed new lesions. Then again, we will have to reconsider immunomodulation. They can be an early form of multiple sclerosis. Then there are another entities called as seronegative demyelinating issues, disorders, which can also present in similar fashion. So everything depends on the clinical judgment and the clinical condition of the child. And sometimes we may even have to change the diagnosis. We had a child who presented exactly like a demyelination, but turned out to be a glioma later. So we never know. That is why we have to keep a close follow-up of these children. Whenever with steroid, if the child has not responded and on follow-up if the child has deteriorated, an immediate imaging is required for these children. Anything else? Should we repeat antibody test to know whether they became negative before stopping steroids? If we can do an antibody titer, yes, it does definitely help, but just repeating antibody test will not be of much use before stopping the steroids, because you're giving it for 2 years period. Just go on monitoring the clinical condition, and you can look at titrating the look for the antibody titers. The titers will be of more value in deciding about stopping the steroids. Anything else?
Shall we wind up? Shall we wind up?
Yes, ma'am, sure.
Okay. If you have any queries, you can get back to us anytime.
Yeah, definitely. I'll send you the video of that gate, what I was talking about. I think that is not opening clearly in this. I'll just post it to one of the PG students and they can circulate it. Not a problem. Thank you all. Thank you, ma'am.